This is the second in a series of presentations on the topic of disorders affecting the diaphysis, metaphysis, and physis in veterinary patients. The intent of this presentation is to describe growth disturbances identified during radiography of long bones in cats and horses. We're going to learn about one growth disturbance in each of these species. So by the end of the presentation, you should be able to recognize and describe the radiographic findings of feline femoral neck metaphyseal osteopathy and equine physeal dysplasia. Let's start with the cat. Metaphyseal osteopathy in the cat affects the femoral neck, and that is in the proximal femoral metaphysis, and it can lead to pathologic fractures, which is generally how we recognize this disorder. And these are spontaneous capital physeal fractures or Salter-Harris type 1 fractures involving the proximal femoral physis. Cats involved are less than 2 years of age, and so it's a little bit older than you might think of as a growth disturbance. The Siamese cat has been overrepresented, and this disease predominantly affects neutered males. Histologically, there is necrosis in the proximal metaphysis of the femur, and oftentimes there's an insidious onset of typically bilateral hind limb lameness, so this usually affects both hind limbs. However, it's not at the same time, so a patient may present with a spontaneous capital physeal fracture on one side and then a few months later present with it on the other side. We need to consider how this is in contrast to the slipped capital femoral epiphyseolysis that occurs in young cats that have undergone prepubertal gonadectomy. And so those patients may not have anything other than the capital physeal fracture, whereas the patients we're talking about now may have some other radiographic findings. And those radiographic findings include femoral head and neck, particularly osteolysis, so areas of lysis, areas of radiolucency, and that is because of the necrosis that is happening in these portions of the femur, and there's bone resorption and or lysis going on. There will also be associated sclerosis, particularly of the metaphysis, and that degree of osteolysis and sclerosis of the head and neck will progress with chronicity. And then because of the capital physeal fracture, there will be varying degrees of malalignment of that capital epiphysis or the proximal femoral epiphysis. So here are orthogonal views in a 15-month-old neutered male domestic long-hair cat. This patient is presenting for bilateral hind limb lameness. When we look really on the ventrodorsal view, it's going to be challenging to identify the abnormalities on the lateral view. On the right side here is our femoral head, and it is not aligned with the femoral neck. So this part of the femoral neck here should line up with this part of the femoral head. So this is actually our capital physeal fracture. And if we look at the femoral neck or proximal metaphysis, it actually has some sclerosis. So again, the medullary cavity area should really be fairly lucent like the rest of the femur. On the left-hand side, there is some malalignment of this femoral neck with the femoral head. However, what I really notice more is that there is some sclerosis of the femoral neck and then probably some of this thinning or osteolytic resorption. Here's another patient, slightly older. This is an 18-month-old neutered male domestic short-hair cat. And in this patient, again, our findings are going to be most prevalent on or easy to see on the ventrodorsal view. The right-hand side is actually normal, so there's going to be a little bit of sclerosis of the metaphysis, and then it's going to be fairly uniformly lucent like the rest of the femur. Notice the epiphysis here, the femoral head, is lining up appropriately with the femoral neck, and you can compare that with the previous patient. When we look at the left-hand side, and we can tell that the patient was lame on this side, because if you remember looking at the soft tissues, we can actually see that there's some atrophy. So this patient has been lame, not just acutely on this leg. when I look for where the femoral head is, it's still within the acetabulum here, but this part of the femoral head should be lining up with the femoral neck, like on the right-hand side. And here's actually the femoral neck here. So there is malalignment of that neck and that head. So that's our capital physeal fracture. But then if we look at the femoral neck itself, it's actually thinned or narrowed from the resorption or lysis that's happening compared to the normal right side, and there is more sclerosis of this femoral neck than on the normal right side. This is the same patient, and I wanted to show you an additional view that can be helpful when we're looking especially at the femoral head, femoral neck, and even the rest of the pelvis. So this is our kind of our routine extended limb ventrodorsal view, but on the right-hand side of the slide here, we have done a flexed limb ventrodorsal view. And when we do that flexed limb, maybe it's easier for you to see the femoral head here not lining up with our femoral neck. So sometimes you can see the malalignment better on the extended limb view. Sometimes you can see the malalignment better on the flexed limb view. Compare that to the normal side. So this is what alignment should look like. So again, we have our capital physeal fracture here. And then this is our final example of a patient with this femoral neck metaphyseal osteopathy. On the left-hand side of the slide, we have a patient with an extended limb ventrodorsal view. When I look at the right side, the femoral neck is fairly sclerotic. There is probably a wider appearance of this femoral physis than I would normally see. On the left-hand side of this patient, I can see that that femoral neck is not lining up with that epiphysis or the femoral head, so we actually have a fracture there. And then our femoral neck is probably thinner on the left-hand side compared to the right side, more irregular and sclerotic. And then on the right-hand side of the slide, when we do our flexed limb ventrodorsal view, hopefully it's easier to see that on the right-hand side now, there is a capital physeal fracture. This femoral neck is no longer aligned with the femoral head. Compare that to our previous slide, how they should align. And then on the left-hand side as well, here's our femoral neck. It should be attached to that femoral head. So we have bilateral capital physeal fractures that presented at the same time on this patient. Like I said, in practice, oftentimes we'll get a patient that has this and we'll, do a surgical intervention, which is typically a femoral head and neck ostectomy or FHO. And then they may come back in a couple months with the lameness on the other side. And so we should tell the client about the fact that this might happen bilaterally. Now let's talk about the equine growth disturbance that we're going to focus on in this class, and that is physeal dysplasia. And physeal dysplasia is going to affect the actual physis, typically in the distal radius, distal tibia, and distal third metacarpal or metatarsal bones in the horse, although I have seen it in other bones. These are young patients that are growing, usually weanling or yearling age. The distal third metacarpal and metatarsal bones are generally affected at a younger age than the distal radius and the distal tibia. Larger and more rapidly growing breeds and or those that are on high protein food additives may be predisposed to this disorder. And there are some thoughts that there may be an underlying hereditary or developmental abnormality, and some patients have said that this is, or some scientists have talked about this being maybe an osteochondrosis type disease, and we'll talk about osteochondrosis later on. It can be nutritional or metabolic. The exact etiology is not known. There are other terms that you'll hear used, including aseptic physitis, so not an infectious disorder, epiphysitis, and epiphyseal dysplasia. But since most of the findings are really of the physis, I will have us use the term physeal dysplasia. So this slide just shows the normal distal radial physis in two different patients, a 2-year-old horse on the left and a 3-year-old horse on the right. And just keep in mind that the normal distal radial physis is fairly wavy, and there will be a thin little area of metaphyseal sclerosis. Again, that's because of that active growing and remodeling. But notice what it looks like from medial to lateral and from cranial to caudal on that distal radius. And then as they get older, the physis will be less evident. Typically, the distal physis probably closes around 3 to 3.5 years of age in the horse. Again, just kind of notice what the metaphysis, epiphysis, and physis look like. Here is the distal metacarpal bone in both a 1-month-old horse and a 3-month-old horse. So here are our proximal sesamoids in these patients. Here is the physis, again with just a little bit of sclerotic, thin metaphyseal bone adjacent to the physis. And then at 3 months of age, we're starting to close. Again, just compare what the metaphysis, epiphysis, and physis looks like in the normal patient. So radiographically, again, we're going to see things that are centered at the physis, and probably the most important abnormality that I will identify is irregularity of the physis with asymmetric widening across the physis. So one side will look a little bit wider than the other side. And then notice in this example patient on the right of the slide that there is asymmetry now to that metaphyseal area. So it's broader and more flared on this lateral side here. Here's our accessory carpal bone, so I know what side is lateral compared to the medial side. And then sometimes we'll have more sclerosis, so not just that thin normal sclerotic region. So a little bit of adjacent sclerosis in this kind of area where the physis is widened. And then if it is severe enough, it will actually affect the shape of the epiphysis, because what's happening is they actually start to affect their growth. And so one side will keep growing normally, which in this patient is the medial side. And then the lateral side, even though that's the wider side, is actually not growing as much. And so that epiphysis is shorter on the lateral side than it is on the medial side. So it's kind of more wedge shaped. And in some patients, you'll start to see periosteal new bone or lipping along the metaphysis and the epiphysis. And then they can actually have some extracapsular soft tissue swelling. It's usually fairly mild. As you notice in this patient, it's not uncommon for physeal dysplasia to lead to angular limb deformities. So in this patient, because the lateral side is not growing properly, the medial side keeps growing, and so that distal limb starts to laterally angulate. And so because it's centered at the carpus, this deformity is carpal valgus. So valgus deformity is when the lateral side or the distal part of the limb is more laterally angulated. So it's quite common for us to see carpal valgus, and then fetlock varus is usually the angular limb deformity if the distal metacarpal 3 or metatarsal 3 is involved. Here's an example of a 6-month-old filly with crooked legs, and oftentimes both will be affected, although to varying degrees. And on this patient, the right side is affected, again, mildly, but there is some widening over here compared to here. There's a little bit more flaring of the medial side of metaphysis, a little bit more sclerosis. And if you notice, when we draw a line down the long axis of the radius, and then compare how that intersects with a line down the long axis of the third metacarpal bone, there is a mild carpal valgus, so distally laterally angulated. The left side is probably a little bit more affected. Again, kind of asymmetry across the physis here. It's hard to say which side is wider, but the physis is not symmetric across. And then there's some metaphyseal sclerosis. And again, we have a distal limb that is laterally angulating. Again, typically because the lateral side is not growing as fast as the medial side. So we have carpal valgus. Here is a 9-month-old colt. This one was just presenting for laying down more and some palpable swelling of the carpus. I have a lateral and a dorsal palmar view, and the dorsal palmar view probably shows our findings more easily. Notice at the medial side, the physis is quite a bit wider than at the lateral side. This also has this kind of flaring of the metaphysis and epiphysis at the medial side, and even some solid periosteal reaction along here, and then some sclerosis in the metaphysis adjacent to this abnormally wide physis. This patient, we don't have enough of the limb to decide if there's any carpal valgus, but it doesn't look like there probably is very much. On the lateral view, we can see along the caudal cortex of that distal radial metaphysis, there's also a solid periosteal reaction, maybe a little bit more challenging to see that kind of widening of the physis. Here's a yearling colt who presents with swelling at the medial side of the carpus. And on the radiographs, particularly the DP view of the carpus, we can see that that swelling is really this kind of osseous enlargement, which is a smooth periosteal reaction as well as broadening and flaring of this metaphysis that also is sclerotic. The epiphysis also has some periosteal reaction, and we can see that this physis is widened here compared to the lateral side, and this is, again, physeal dysplasia. On the lateral view, it's kind of more challenging to see the changes, but there is a solid periosteal reaction. And then this patient, we don't have a lot of the limb, but again, if I look at the long axis view of the radius compared to the long axis view of the third metacarpal bone, they don't have parallel lines, and so there is a little bit of a mild carpal valgus. Here's a patient that has it affecting the distal third metacarpal bone. This is a 5-month-old filly who's coming with a crooked leg. And if you notice this distal third metacarpal bone at the physis here medially, so our label is telling me that this is the lateral side, medially there is quite a bit of broadening and flaring of both the metaphysis and the epiphysis. The epiphysis is more wedge-shaped, so it's shorter here on the medial side. This physis is wider. There's some sclerosis, so that's all the radiographic findings of physeal dysplasia. And then the distal limb is angled medially, so this is a varus deformity. They usually also have a rotational deformity if you look at the patient clinically and radiographically as well. So just a quick discussion of angular limb deformities, because by now in our musculoskeletal presentations, we've seen quite a few things that could lead to angular limb deformities. And these occur in our skeletally immature, still growing animals. Of our veterinary patients, the dogs and horses are the most commonly evaluated for angular limb deformities, but any of our species can be affected. And there are many causes, some of which we've already learned about, but especially in the horse and sometimes in the dog, we can just have soft tissue causes, which are ligamentous laxities or contractures. We can have physeal trauma, so we talked about Salter-Harris type fractures, so that sort of trauma can certainly lead to angular limb deformities. And remember, particularly in the dog, it happened when you had the type 5 trauma, Salter-Harris fracture of the distal ulna, because then you get abnormal growth between the radius and the ulna. Some patients actually just have asynchronous growth between the radius and the ulna, not from physeal trauma. That can happen in large breed dogs, so that can cause angular limb deformities. And then we've talked about it with hypertrophic osteodystrophy, so potentially a sequela to that. We just talked about physeal dysplasia in the horse as leading to our angular limb deformities. And then later on, we'll talk about incomplete ossification of the cuboidal bones in the horse that can also lead to angular limb deformities. More explanation and additional examples, as well as information regarding other growth disturbances that we won't discuss, can be found in the textbooks with the chapters and pages listed here. And when you're looking for specific examples and text about the disorders we talked about, be sure to use the index in the textbooks to find your item of interest.